The broadcast is now starting. All attendees are in listen-only mode.
Good morning and welcome to today's webinar, Making Accurate and Complex Implant Models Within Minutes. My name is Sarah and I'll be facilitating the webinar. Before we begin, I just want to go over a few housekeeping items. First, the webinar is being recorded and will be available on whitmix.com in 1 week. Second, it is approved by the NBC for 1 scientific credit, and within 48 to 72 hours, you will receive an email that includes the CE test and a link to the recording. Finally, if you have any questions during the webinar, please type them in the questions box located on the right-hand side of your screen. We will be answering all questions at the end of the presentation. Now I'd like to introduce today's presenter, Dr. Joseph Massad. Dr. Massad holds faculty positions at Tufts University School of Dental Medicine in Boston, Associate Professor in the Dental Department of Prosthodontics at the University of Tennessee Health and Science Center College of Dentistry, Memphis, Tennessee, and adjunct associate faculty with the Department of Comprehensive Dentistry, the University of Texas Health Science Center at San Antonio. Dr. Massad is a fellow of the American College of Dentists, the International College of Dentists, and Regent Fellow of the International Academy for Dental Facial Aesthetics, and is an honorary member of the American College of Prosthodontics. Dr. Massad practices privately in Tulsa, Oklahoma. Now I'd like to turn it over to Dr. Massad.
Welcome. Well, today we're going to talk about making accurate implant models, but of course we're going to be also talking about the impression portion of it and how we can actually do this very simply and reduce a lot of the waste that we have done in the past. So we'll go on from here. I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. These are a disclosure I'm going to give because I've virtually consulted with about 40 different manufacturing companies, but this does not reflect upon this presentation. I always like to begin by saying if you're going to quote what I say or publish, then it becomes your responsibility to date when I said it or published it. And I thank you. This was given to me by Dr. John Anderson and Dr. L.D. Pankey, and this is so true. Things are changing. It seems now month by month versus year by year. So what has changed in the area of casting prosthetic models? Just about everything except the name and our attitudes. The objective will be to demonstrate a technique and describe the material for casting an implant model with an elastic gingival tissue overlay with high confidence of accurate definition to assure final bar or connected unit passive fit. And today's technology with milling both bars and fixed cases, it's extremely important that we have accurate impressions, especially because we are scanning the models in most cases. So basically what prosthetic restorations have priority as far as detail for accurate fit? Would it be the most costly cases? Well, that's a good consideration. It's going to cost the practitioner and or combination lab if it doesn't fit because they have to redo it. The most technical challenging cases, you sure don't want to have to go through that all over again and retreat a patient. How about patients with limited bone structure? Also very important. Not only are the implants need to be in the proper position, but the prosthesis has to be balanced so there is no undue stress on the implants. Patients requiring multiple crowns. Gosh, that would be another one I would really highly consider. How about the totally edictions patients? Well, now we don't have anything to hang on to, so basically we have tissue that is generally soft, and it's important that we have an accurate rendition of that patient's tissue and bone at the right time when they're slightly hydrated. Otherwise, we're not going to have a good cast. How about combination tooth and edentulous scenarios? Anytime we have free-end saddles or even combination implant and edentulalism, we're going to be making any type of detachable prosthesis. It's extremely important that we have accurate models for this. Well, you know, we started out some years back in the 80s doing little overdentures. And for a while they were rather successful, and I think still have been. However, there were some speed bumps that we got into. And part of the speed bump was the prosthesis would fit to an extent that they would rock a little bit. Maybe the tissue was taken dehydrated. Maybe we didn't have a great impression. Therefore, we were only concentrating many times on the implant impression, and we were not really concentrating on all that tissue around. And overdenture is what it says. It's an overdenture. It's still a denture. So it's going to actually have its retention increase from the implant, abutment, and retentive elements, but the compressibility will still be on the tissues. Now we take a look. We have where we did a lot of castings. We did cast bars, or we did multiple implants. Very important that we have accurate impressions. We're still not actually scanning the mouth at this time with the implant. We are actually making the model with soft tissue, and then if we're going to be doing the milling cases, we'll be actually scanning this. In these cases where we did not scanned cases, it was also extremely important. We're doing 3-unit bridges, we're doing multiple units. All of these are extremely important for the prosthetic technician to have an accurate model. And then we got on doing what they call the all-on-4. Now there's another system very similar called SmartFit. And these basic systems were utilizing 4 implants to put in a fixed prosthesis. Boy, how important is that to have an absolute, as perfect as possible model? We're off 22 microns and it's not going to fit well. We'll put torque on the implant, or we'll have to tighten that in. And these are cases that the metal actually, generally it's one piece. We go right into the implant and the abutment is actually skipped. So here's just a closer look at a case where this was a milled case. Very important that we have an accurate impression for this and an accurate model for this. And we did the shiny belly. In this case, we actually even extended the part of the cameo surface out labally to give additional lip support for this patient. And there's just a close-up. Yes, you've got to have the implants correct. You have to have the impression correct, and then you must have a definitive model that can be scanned to do something like this and have it fit the first time. So I think to preface this topic, we're going to have an optimal impression. So we're going to go through this rather quickly, and the method is a method that we utilize in order to do several things: control our hand movements, control the thickness of material, impression material, and to be able to make an impression of both the implant surfaces and the tissue surfaces. You can go to one of our articles in Compendium, October 2007. Myself and Dr. Cagna published articles in this respect. So we have a patient who had 6 maxillary implants and 4 mandibular implants. And as we take a look, we do see divergences between each of the implants. And this is going to now dictate whether we're going to utilize a closed method of impression making or possibly an open tray type method. And we begin for each. What's important when we put in the impression copings, that every practitioner knows that sometimes you have a little tissue that may not let you twist it all the way in. In cases like that, I think we can use a small little diode laser and clean that out. And just kind of demonstrating that we've already got the implants in now, but we use a diode actually even for retraction. But what we find is many times there's tissue that actually gets underneath before you even get the implant coping in. And we see that. Many times we take the healing abutment out, and what happens? The tissue just is like a sphincter muscle. It closes back, and we can't always get it in. Another tip on making sure that you seat it correctly would be that we don't push the locking screw all the way in. We need to get the bilobe, trilobe, quad lobe hex. We've got to be able to engage that tactily before we actually engage the locking screw, because if the locking screw is all the way pushed up, many times we will actually not be in that actually locking position, and you can actually tighten it, but there'll be a space. And then of course we do a radiographic review of all this. As you see here now, I'm just leaving the screw out. I'm supporting the impression coping in, and then I take and begin to lock the screw. So tactily, I've twisted in the impression coping until I could feel, in this particular case, the little trilobe on the inside. And once I knew that was locked, then I went in and engaged the locking screw. And of course, we do a radiographic interpretation to make sure that it is completely seated. Now, what you're seeing here is maybe different than the radiograph, but this is the same patient. But what I did here, if you look closely, in the center we have 3 impression copings, and those are closed. But then as you look to the one on the left and 2 on the right, well, they're open. Well, this was the most divergency that we had, was on the posterior. And the rationale for doing a combination open and closed method in this particular case would be that we didn't have to cut as many holes into the tray, because many times when you perforate the tray multiple times or use a complete open tray, where is it going to get its support or stiffness? So there's issues if they're not exactly perfectly in the center of the tray. You will have to cut multiple holes, and generally those multiple holes will become just one big hole, and now you don't have stability of the tray. In this particular case, we used 3 closed impression copings, and on the posterior we used 2 open and 1 open on the opposite side. So this is going to actually give us a much more stable tray. Now we're going to use a controlled heated water bath, and we're going to put in a clear tray which is thermoplastic and can be shaped directly into the patient's mouth. The rationale behind this is, instead of making a 2 appointment with the custom tray, it's extremely efficient and accurate if we can use a thermoplastic tray that's moldable in the patient's mouth. And we don't want to oversize it, but we'll let the patient compress it. So the patient is going to suck inward. They're going to smile a little bit, and as you will see, they actually have shaped the tray. So now the tray is really shaped. You can see on one side how the tray just warped in, and you can see, I can see each of the implant impression copings. In fact, I know where each of the screw heads are. So it's going to be now much easier for me to negotiate and put in the open up the tray, where I'll be able to retrieve the open tray impression copings when I finish the impression. Now, what we're going to be doing here is we're putting adhesive on the inside portions of the tray and on the palate. Now, if you noted, this particular patient has edentulous ridges in the posterior area, so virtually nothing posterior to the second vi. So we have edentulous areas, and then we have in the anterior, we have the 6 implants. So I'm now going to utilize a a very rigid facet PVS impression material to make tissue and implant stops. So we're going to now inject, if you'll notice, more material where there's edentulous in the back, where these the tops of the ridges, and then a smaller amount where I'm going to actually be opposite the implants, and then some on the palatal area. Now, if you'll take a look, this is going to be placed into the mouth and let set. So when I remove it, I will have no rotational movement, anterior or posterior. So I want to direct my second time to go into the mouth. I want to direct it to where it has a single path of insertion and there'll be no rotational movements. One of the problems we have when we make impressions is that we move before the material polymerizes, or we rotate our hand a little bit, or the assistant takes over and we get slump. Slump is where the material, your hand goes down, the material stretches a little bit, it's like it's beginning to drip internally, and you may go back up, but you can't really retrieve slump in most cases. Now I'm going to place this into the mouth, and this material in the mouth is 1.5 minutes, which is good. You want something fast. The longer you hold your hand, the more fatigued we get. And then as I take it out, I want you to analyze. You can see the ridges in the posterior area, and you can see all of the indentations for where the implants are. I can identify the 3 closed in the anterior, and on one side I've got 2 open, on the other side I've got 1 open. So I've identified exactly where everything is, and so I can cut the hose at this point and begin. In some cases, if it was a fixed case, I could do borders and wash at the same time. In this particular patient situation, we're going to actually make her a bar and an overdenture, and the reason for that is to fill the face. And if we did a fixed case, we wouldn't be able to fill the inside to help support the facial mask on the outside. So let's take a round burr and cut holes in those 3 areas. Now I still have a very stable tray. I want to try it in and make sure I can retrieve it easily. And now I'm doing borders separately of the final wash. The rationale behind this is if it's going to be an overdenture and I need to respect the peripheral anatomy, then I need a functional impression around the peripheral borders. Therefore, I will go in, have the patient go through patient movements, not necessarily doctor-directed, but patient-directed movements by sucking outward, smiling, opening wide, breathing in and coughing while we occlude the anatomy. And when I do that and remove the tray, I will see where the functional pressure area, which now I've identified before I even do my final wash, and then a very small area off of the top of the border of the tray to allow my final wash to flow very naturally. So now I've done this. I've cleaned it up, and I'm ready to do my final wash. The final wash will be done in a medium to light viscosity, except directly opposite the implants, I will actually inject this very extra rigid facet material into the tray to support the analogs at the time of pouring up the model. And you're going to see this. So I'm injecting the extra rigid directly opposite the implant copings. And then I'm putting a monophase, and this particular material acts as a light viscosity. It's called a mono, and it's because it doesn't drip until I put pressure to it. And then I'm going to inject around the implant copings with this viscosity. You see nothing's dripping here, but this actually will react as a light viscosity. I then will place the impression in. I have positive stops. I repeat the border molding procedures with the patient. And this is about a 2-minute set on the final material here. And then I should be able to take my finger and take all the material off wherever the heads of the locking screws are. You can see those right there. So now I can retrieve those very nicely. Now we're removing these. And now we're going to deliver the tray impression. Now, you see a very nice impression, very little voids in here, and I've captured everything I want. We're going to make a soft tissue model now. Now you see the analogs are now placed with the impression copings, and the material that the impression coping sits in actually is very stiff, because as you recall, I put that rigid viscosity inside the tray so that underneath the light viscosity, which was injected around the impression copings, it would support it. So you're not going to have something that will actually, your finger won't just accidentally move the top of the analog, and many times that has been an issue. Okay, improvements in casting models. Fluid pores does not require vibrating when compared to conventional medium viscosity, which does generally require vibrating. And this is many times a problem. You vibrate many times, you will create bubbles. And if the analog is in and they're stiff enough that you could actually move this. So the advantage of a fluid pore would be decrease and in most cases eliminate the pitting and creasing. It decreases movement of the implant analog that I just mentioned, reduces the amount of material waste, and significant reduction in cleanup. So what do I have here? Well, I have a plastic container that generally they deliver models in, and we cut a hole on the top of it, and you see something blue in the bottom because I didn't have the right size, so I didn't want to have too much material in there, so I just use that as a spacer. But this is nothing more than a container that must be sealed off. And I'm going to box the impression with either an alginate, maybe that little Play-Doh, or a little bit of like Wonderfill, and just so I will have it boxed nicely, and I want to do this rather quickly and accurately. So in this case, we're actually putting the alginate. This particular alginate has a 100-hour life, and so you can make several models on this, but it won't desiccate for several days. Now you'll see I have the alginate all the way to the top of the tray, and now we're going to take and cut the handle off of the impression tray, which we did. And I'm going to take now and push the impression all the way down to the height of the peripheral border. Might be a little blurry, but I want to give you a close-up here. You can see this here. And now I'm going to actually proportion the water powder ratio. In this case, I'm using Flowstone facet. Recommended powder to water is 100 to 24. I'm going to use 200 grams here. Therefore, we'll be using 200 to be 48. And this will automatically be weighed, both water and powder, to the exact measurement. I'll just kind of lightly stir it and then immediately put it in to my VPM2, and I will then spin it. And there is a recommended spin time and there's a recommended speed. And I think we all need to really adhere to the manufacturer's recommendations because we want to get the actual best fluid material that we can that will actually set up to accuracy. So you see, we're just pouring it. Now, don't pour it this high, but just to kind of demonstrate, as we're pouring this in, there's no mess here. Here's just another view of pouring this in. As you pour it in, you don't even need to rotate the container it's in. It's liquid. Now, I want to make a point here that's important to make sure that we have it sealed, because these containers don't have any type of locking mechanism for keeping out any liquid. Put a little bit more alginate so that when I compress the tray in, it would flow over the edge of the container so that when I close it, it would seal it. And we poured up to the size of the model that in this particular case many times if you want to make it like a crown bridge case, you may want to make 100, and then you'll just go ahead and put in your pins and so forth. So let's go ahead now that we have it, and we'll unscrew the open tray and then extract it. You can see the integrity of the impression. And why are we taking this out? Because I'm going to go ahead now and do a verification, which is, if we're going to do a bar, I think that's important to do that. So we're now using the open tray impression copings because they're easiest to use. Now, it depends on what manufacturer you're using this with, because some manufacturers, you can't use their impression copings. So you'll have to use a non-engaging type of coping in order to make a verification. Verification jigs are not easy to make in the mouth, and there's not that many materials that are approved by FDA that you can cure them in the mouth that have that much accuracy. So if they're really just only in front, it's maybe a little bit easier, but I like going ahead and making the verification on the definitive model, and if it fits well, I don't need to cut and take another impression, but if it doesn't, I've got the option of cutting it and retaking it. So see, we actually made it in sections, and then we're going to now, this is a light curing material, and we're going to fill this, and then we're going to light cure, clean it all up. I'm putting a little excess in here right now. Extremely brittle. It's only approved to be used to be made outside the mouth, but you can put it in the mouth for your verification. It just, you can't put it in uncured. So this particular and I want it brittle because if I get any tension at all, I'd like to see a crack in it because I want to make sure that everything goes in passively. Okay, so when it's completed and cleaned up, I need to go into the mouth and try that in. And I would always take a little diode laser and clean this out because you want to passively make sure it goes in passively and seats. And initially I did what they call the one screw test. Many of you may have done this before. I only put one screw in it in radiographic. And the one screw, if everything fits well, everything should actually seat. Now, as I put each one of these in, I want to make sure I don't feel any resistance. If there's resistance, I may want to stop. Well, I will, because something's not right, which means you're going to probably have to cut that one particular section and then see if the others go in without resistance. Then you know exactly which one to cut. You don't need to cut all of them if it doesn't fit in the mouth, just the ones that you feel resistance when you're trying to lock in the pin and you feel like it's rubbing up against something. We ready-graphed these to be fine, and then the models were scanned after the prosthesis was actually in its waxed form, so we could actually scan the amount of room we needed and the bar design. So when we completed the bar, we actually, if you'll see, we put two, these are the micro ERAs. The locators are a little bit too wide in this case, so I use these micro ERAs, and then I just use the, on the posterior, very similar, it'd be like the hater clip and bar here, and we'll use the gold clips on this case. So now, will this fit passively? You see a little blanching of the tissue. Take a little laser, just open that up. But this was by design. We didn't want there to be, you know, anything in there that would actually create an opening. So I would rather blanch slightly and then just clean that up, and then do the one screw test again, ready graft. If this fits well, then put in the rest of the screws. So this is what we're doing here. So this is a one piece with the abutment in the bar all in one piece. So when we completed both bars and the prosthesis was processed, we went ahead and delivered it all on the same day. You say, why? We needed a cameo surface to support the face. This patient had a really sunken in face, smoker for many, many years. So we were able to make an accurate cameo impression and use the filled inside. And that then affected the appearance of the outside of the face. That's what you like in every case. There was her before when she had teeth. You see the asymmetry. And there was the completed prosthesis. Now this was, of course, after the meat was put in, we waited and then put implants in. Definitive prosthesis with the bar. So you see her face. We were able to support it. We really couldn't fill the lips much because the vermilion border of the lip is the toughest. If you fill the inside of the face, the vermilion border actually gets a little thinner. Think of a rubber band that you stretch out. But the face and the lips and the philtrum will actually be filled from the inside. And so she decided to have the upper lip done with some enhancement, and that was just fine. But we knew what we could do would be really assist in filling her face. Okay, the Flowstone facet that we used is ISO type 4, fast setting fluid low expansion base stone. And as I told you, the 22 to 24 is the water. I use the 24. I want it to be liquid enough, so I went to the max. Working time is 4 to 6 minutes, which doesn't take you much time. Setting time, believe it or not, is 8 minutes. The setting expansion is 0.8%, and it has a compressive strength of wet of 6,000 and 12,000 when actually dried. You can compare that with any of your dye stones at this point. Now let's go ahead and just do one on the dentate. We're going to do it very similar, especially if you're going to be doing multiple implants or maybe even a prosthesis. I always want to have the most accurate model. I'm going to use a little different material to box it, so I wanted to kind of show you here. So we cut the handle off. Now we're going to use the other material we showed you, and this is a little bit softer than the Play-Doh. And I just put my finger around and make sure I have the peripheral row exposed. Okay. Ratio will be dispensed, and then I will mix and extract the air, get a nice fluid mix, and pour. A little trimming, and then we have our final model. But the peripheral area here is what we don't always get. Well, you don't always need it, but you do need it in any prosthetic that is going to be either detachable or that you need to use the phalange portion to fill the face, and you are not able to do a individual fixed case. So here's one for just an upper denture. Once again, cut the handle off, size it. I just cut a hole in the container. Now I'm going to go ahead and put the material in. The tray fits fine since the handle's cut. And now I'm mixing. Actually, this is already mixed. I'm just actually compressing this into the container here. Now, what do we actually need for the peripheral anatomy? The peripheral anatomy is extremely important in any detachable prosthetic. This is the part that seals it. This is the part where we get retentive area. So the height, if you take a close look at the edge of the border, we only want to actually go from the height approximately 2 millimeters. Roll it to the labial buckle. That's it. You don't need anything else exposed. And you can go all the way back to the postpalatal zone, which is important that we identify that also. Now, you see, I didn't get enough material, so I've got to do something like this to make sure I have an excess. Because if you don't, I assure you, you're going to be frustrated because you pour the liquid in, it will just all come out the sides. So I need a little extra here. Now, when I close this, you'll see that I should have it sealed. Now, when this happens, sometimes some of the material will come back in. Just put your finger back into the orifice at the top, and you can push the area around the peripheral border and just make it nice and level. So sometimes a little excess when you close this will hold. You can clean it up. I've had questions before about this material and the cost and the usage. You can reuse it as long as the model is disinfected. This will be strictly in the lab. More than likely, you've already disinfected the impression. And if you want to box it and reuse the material, as long as once you've completed with it, then the model's been disinfected, should not really be a major issue. The algin, of course, can only be used once. Now I want you to take a look. See, I put my finger back in and just cleaned it up to make sure I just had the height, the peripheral border, and around the side. You see now I'm going to go ahead automatically mix. This is a Flowstone. I'm using this at 1 to 24. I'm using 200 grams, so it's going to dispense the water automatically, and then it's going to dispense the powder. And while it's dispensing it, actually is vibrating to make sure it sifts and there's no clumps and it's all dry. So it will actually let you know when it's at 100%. In this particular case, I'm not even mixing it. I'm just going to put into the little spinner here. I'm just going to put in this, and I already have it programmed. Now, I actually utilize a full 30 seconds, and I go to about 400, go as high as 500, and their recommendation, I believe, was between 3 and 5. And I just with trial and error, I like a little faster spin. I don't want any clumps, any lumps. I want to be able to pour it exactly, and I leave it on a 30-second. And you could actually read the guidelines and now, if you take a close look, I'm starting to leak a little bit on the bottom of that. You see, so if you don't seal that off, you see where the liquid is, it could actually just come all the way out. So I want to emphasize you need to lock that in. One time I was thinking about making one of these containers with a lock, and I actually designed it, but you know, you have to think about how many people are really going to use this. I love it. Look at the countertop. This is in real time. I mean, there's no mess. You think about the amount of cleanup. It's amazing because in our office we actually at one time calculated cleaning up and sterilizing, cleaning up laboratory was about 13%. Oh my gosh, that's amazing. So if you're going to do this in your office, which I highly recommend that dentists begin to pour these up in your office, because especially on a removable case, what can you do? You can actually make your bases right then. So I actually will make my impressions, pour this up, and within 20 minutes I'm making my bases, and I go take records. So take the glove, just take all this material off, and you'll have to throw part of it away whenever you get little bits of stone in it. But if you do reuse it, then you must, you know, disinfect the model. And even in our lab, we use gowns and we use gloves. And you trim it up, and you've got a nice model. Now, I'll make my bases. I go in and take my records, and all in a single appointment. And if you do it very accurately, you can bounce from a hygiene patient, for example, then go over and have your assistant or yourself, you make your base, get this completed, and patient maybe just had a relaxful cup of coffee or something, and then you go in and make your records. It's been very efficient in our office utilizing liquid material. I've been doing this for several years. I'd like to emphasize that you have options today for both the dentists and prosthetic technicians to think about. The technique I suggested for impression making is only one of several. It's the one that we use because it keeps us straight. It keeps the hand from rotating. It gives us the thickness of impression material that we need in the elastomerics to be accurate. We have actually done an internal study where we were allowed, because it benefited another company, to make 85 bars, okay? And it benefited them because we were actually trying to help them in their early years. And so we were able to now test the impression procedure and the pour-up procedure using this liquid pour material. and make multiple casts on multiple patients and determine the success rate. It was absolutely amazing. The amount of redos, and this can be verified with our records, but we have not published this yet, was about 2%, which is great. And that 2%, we actually found out what the problem was, and it was if you don't get your impression coping back in exactly, or you don't close up the head of the locking screw many times, that will do what? Well, a little material gets in there, and you don't seat the impression coping all the way back in. So it was an error that we actually had. As far as the dimensional change of the cast, we actually felt this was extremely accurate. And there's so many other variables that can decrease our success rate that we have to be able to, to try to minimize as much as we possibly can. I promise I would give everyone about 10 or 15 minutes of questions, but I also have the test questions here for you all to take a look at, but I want to thank everyone who's attended this presentation. And if you just go to my website, joemassad.com, you can contact me with any questions you may have after this webinar has completed. Let me show you the test questions, and then I want to open this to question and answer if I could. So,
all right. So if any of you all have questions, just remember to please type them in the questions box at the right-hand side of your screen. And we will be sending out the test questions, so you don't need to write them down. You can if you do. As of right now, we do not have any questions that have come in, but we'll hold here for another minute in case anybody does have any questions.
Do you want me to show these questions at all?
Yes.
Okay. So let me just show you these. And so the first test question is, what prosthetic restorations have priority as far as detail for accurate fit? I think you all should be able to answer that particular question. I've been asked questions at different seminars from time to time, and I like those who have multiple questions. In my website, you can actually, I have the references listed for quite a few items, for just about everything we do. So you can actually view those and even download some of the publications. Okay, next question is, was the manufacturer's ISO type for Flowstone facet? And okay. Any questions yet?
We do. We have one question, and it is, what alternatives have you used for the putty material? Play-Doh, alginate, or other materials?
Well, the three that I initially showed here, I've used, actually, I have used the silicone, way too expensive, to use, because and it's hard to extract. So if you use the putty silicone, even if it's the lab putty, they're expensive. And so rather than, and if you have undercuts, it's much harder to get out, for example. Okay, so I like alginate. I think that works good, very inexpensive. Play-Doh is not quite as easy, and the other material, I have to remember the name, which I've only been using recently, works very nicely. It's not that inexpensive, but you can elect to reuse it as long as you make sure you disinfect the model, and then I figure per usage that's probably it's called Wonderfill. Per usage, you'll probably get it down to probably 40, 50 cents or something of that nature. So you're not really looking at a lot of cost, but you're really looking at a lot of detail, and that's so important to have the detail and the accuracy. So and I believe really that I go to labs where there's zero boxing. And if you need anything, even a partial, you don't even know where the peripheral is because it hasn't been boxed, the model's been cut. So that's very difficult.
Okay, we have one other question, and it is, why do you use the plastic box to make the model instead of rubber model making cases?
Okay, the most of the items that you receive are not contained completely. You have to put it on the countertop. There's magnetic, there's all, and yes, the ones that you have, I know there are some that you have that are real short. So you need something that you can secure the impression. So you need a container with height to it, okay, so that you can actually box it, and then you can close the top so that it completely encapsulates it and completely seal the edges, which is around the top and the bottom part of the container, so that you can pour liquid in with no spillage. So a lot of the existing containers we have now, you can build them, stack them, but then how do you lock that in to make sure that no liquid goes through it? So so you have a bottom container, then you can actually make it a little bit taller by stacking little parts. But those have to be all seamed together, because when you pour this, it's like water. It will actually go, it'll find any crack there is. So this was so simple just to use a container. Now, when the manufacturer gives you their 0.08% of their expansion contraction, I really believe, and this is now anecdotal because I don't have any science behind it, but when you're in a total container of 4 walls, that you will probably improve the ratio there. You're probably going to be actually more accurate, because the way they generally test that is with an open surface on either side. But for me, it's just so much easier than trying to fool with using the shorter little pieces that already come pre-made and trying to stack them up.
All right. What temperature does the thermoplastic tray require to be malleable?
165, and it is an extremely fast cool rate, so that when it will become very limbery, and limbery is the word, okay? It's got to be limbery. When it's limbery, if it's a small tray, for example, it may take 10 seconds, may take 15 seconds. That's fine. If it's a large tray, it may take up to 35, 40 seconds. But you need controlled heat. You don't want to start the heat cool and raise it. We go at 165, drop it in. It generally takes, average tray, let's say 15 seconds. And you test it. Okay, and when you know that's it, then put it back in the water. Don't take it out and think about it, because by the time you get to the patient's mouth, it ought to be hard. So when you know it's that temperature, you inform the patient, prepare them. It's going to be warm enough, put it in your mouth. Never had anyone have any issues with it. We had studies done at Tennessee at the graduate department because of the rapid cool. So at 165, you're limbery. I would recommend using Columbia cheek retractors, the little metal ones. Have the patient assist you in retraction. Let the patient know it's going to be warm. You go from the water bath straight to the mouth. Inform the patient before you get there they're going to suck and smile or whatever. And on the bottom, they're going to do very similar. The tray will actually shape right to the ridge, and you'll be able to take that tray out of the mouth in about 8 seconds. So from the time it's limbery until the time it's hard is about 15 seconds. Now, the rationale behind the speed is the manufacturer wanted to make sure they didn't keep anything in the mouth and it was too slowly cooling, because then patients would have sensitivity. At the beginning, you may think it's too quick, but what our residents at the university said, gosh, at the beginning I thought I had to be fast. Now I've done it 4 or 5 times. It's great. I don't want to spend time. Once you get it down, it's real simple to do. But I would say 165 is your good level. I would not go to 175, 170, you know, it's going to actually be too warm probably for the patient. But 165, and the cool rate is very rapid.
Okay, we've got 2 more questions, and then we're going to wrap up today's webinar. The first question is, are you making tissue stops for full denture impressions like you did in the posterior subtle areas on implant impressions?
Yes, in the totally edentulous patient, if it's on the maxilla, we put a premaxillary tissue stop, we put a palatal stop, that's 2, and then on either side of the ridge, just anterior to the retromolar pad, to the tuberosity, we actually place 2 more stops. So it's 4 stops on the upper. We go in. First of all, we also use a moldable tray in the mouth. So the tray is already molded. Then we put in our tissue stop. And then we go through the method of bordering and then wash. On the lower, there's generally only 3 stops. So for a lower edentulous patient, we use an anterior stop and then 2 stops slightly anterior to the retromolar pad. Okay? And if it's a flatter ridge, you must use more material. If it's a big ridge, you don't have to use as much stop material, right? So you just want to make sure you calibrate so you don't have a lot of trimming to do. Because if the stops are too large, it means if you have a lot of spillover, you need to trim it just a little bit.
Okay, and our final question is, with your technique, how easy can you remove and put back the soft tissue part in its accurate place?
Well, you know, we've had no issues. I know that there was a time we would actually put more of a kind of anatomy, or we would carve a little bit out to make sure that the soft tissue material would adhere and not move around. And that's a good question. I think a better answer would be, what type of tissue, soft tissue material are you using? Because there is a difference between those. And I think it should adhere very nicely without having to do a lot of extra work or put in any type of diatorics, because we don't even need diatorics for these. So so you need to just look at the impression material, the soft tissue material you're using, or ask your technician which ones they've utilized, and that's the one that I would consider. But they're not all alike, so you need to understand what kind of soft tissue material are you utilizing. Thank you all again.
All right, well, this concludes today's webinar. Just as a reminder, you will be receiving an email with a link to the recorded webinar along with the CE test here in about 48 to 72 hours. And we wish everybody has a great afternoon, and thank you.